lethal dose is a big factor here. The amount of service has to at least match the averages we see in these research studies. And what I'll show you in a moment is that in many juvenile justice systems, they're using these kinds of programs, but providing so little service that they're not having the expected effects, and high quality implementation. And by high quality here, we don't mean clinical quality. We're really talking about organizational issues that have to do with monitoring, identifying clearly what is supposed to happen, monitoring the delivery of service, and taking corrective action. We have tried to translate these findings into something that will help practitioners work with their programs. And you probably can't read that, but this is something my colleague has named the SPEP, the Standardized Program Evaluation Protocol. We've essentially taken the statistical models here that predict effects on recidivism and the factors I just told you about, and turned them into a rating scheme that can be empirically driven by the data from a particular program. So there's the type of service. Some on average have larger effects, some have smaller effects. Here is the dosage, amount of service, duration of service, with targets that are set on the averages that we find in the supporting research. There's a treatment quality category. There's a youth risk level category, and a score that essentially indicates how well a program matches what the best practice would be as we find it in the research. We've done work using this as an attempt to help practitioners get better in line with the evidence in North Carolina and Arizona. Let me show you an example of what we found in Arizona. When we scored the 66 programs in their 5 pilot counties, we found a distribution like this, and nearly 3/4 of those scores were below the midpoint here. Now, Arizona actually has quite a good system, so I'm not, and we have permission to discuss it. So I'm not here to criticize Arizona. I think this is a typical or better than average. It shows there's much room for improvement in the implementation and targeting of these programs. But what I want to show you is the difference between the 25% programs in the top of this distribution and the 73% in the lower part of this distribution. We've tried to do validation studies to get some idea as to whether or not programs that actually follow the advice that comes from research in fact do better. After all, this research wasn't done on their programs, on their kids, in their backyard. It was done someplace else. To put it another way, what is the evidence that evidence-based practice actually makes any difference? The way we approached this was to take the risk factors and the histories of these kids and predict what their expected recidivism rate would be. Different programs have kids at different risks, so of course the recidivism rates are going to vary on that. But if we sort of level the playing field with a constant level of risk, then what we should see is that the better program should outperform the expected recidivism rate of the juveniles they treat. Programs that are less effective will have about the recidivism rate you would have expected given the risk level of the kids. So here for the Arizona sample, which has got about 1,500 juveniles in these 66 programs. Here are the 6-month and 12-month recidivism rates for the low-scoring programs. These are the differences between the actual and predicted recidivism, and you see it's a -1 percentage point. Okay, so the lower-scoring programs are showing recidivism rates. They're just about what you would expect given the risk level of their kids. Now, what about the higher scoring programs? All right, may I have the envelope, please? Well, there's the 6-month recidivism rate. Now, running to the left means a difference that favors the program. So we've got about a 12 percentage point difference between the expected and the actual recidivism rate for the higher scoring programs. That is, the actual recidivism rates are about 12 percentage points lower than what you would predict given the risk level of the juveniles that they're working with. 12-month recidivism rates show very similar pattern here with a 13 points differential. So we think actually here's some evidence that evidence-based practice does make a difference, and here's a procedure for making broader use of the evidence. So my conclusions here are, first, that there's lots of evidence on the effectiveness of interventions for juvenile offenders that goes beyond just what we have for the small number of brand name programs. Model programs, these brand name programs that have been sort of certified by one of these lists, they may well be the best choice when a new program is to be implemented. But evidence-based best practice guidance can support the effectiveness of homegrown programs that are already in place without asking systems to replace them with model programs. But they have to be implemented in a way that corresponds to what the research tells us is likely to produce good effects. Thank you.